Welcome to ICU Primary Prepcast. Hi, my name is Swapnil, and I'm joined by our co-host, Dr. Mike Clifford. Welcome, Mike.
Thanks, Swapnil. Long time no see.
I know you've been busy with your holidays.
I have been busy with my holidays, Swapnil, watching the grass grow, quite literally. We've had some turf put in, and I've been watching it day by day to make sure it takes.
That's such a satisfying and rewarding experience, I must say. Okay, so let's dive into today's topic. This is a particularly very challenging question. And I guess the reason it's challenging for a lot of primary candidates is because the fundamental understanding of the various dialysis modalities that we use in ICU is very limited. So the question is, Mike, for you, describe the physical principles of hemodialysis and hemofiltration, including the factors affecting clearance, and then outline the key components of renal replacement fluids.
Yes. Okay. So this is quite a nice little SAQ. I didn't write it, but I think it's a very nice SAQ. And it's the thing to remember is not to panic. Okay. Everyone has seen a hemodialysis unit being used in intensive care, and we've all seen hemofiltration being used. They're similar. There's some differences, but they're quite similar. And we've all written prescriptions for the replacement fluid. So you can look at that question and say, well, there's 80% of the marks to hemodialysis and hemofiltration, which means I've got to write for 4 marks and 4 marks if I'm writing out of 10, and I need 2 marks for replacement fluids. And I know what's in a bag of Gambro replacement solution, so I can sort of make up that as the principle. So even not knowing things, you can sort of calm yourself down and tell yourself, I can pass this question. Now, if you're not exactly sure about hemodialysis or hemofiltration, just write what you know about, because you might get enough marks to get through it, okay? So hemodialysis, the first thing to think about is that it's solute movement across a semi-permeable membrane, which occurs by diffusion down their concentration gradient, okay? And the concentration gradient is maintained across the length of the membrane because there is a countercurrent dialysate solution moving on the opposite side of the membrane. So it's not just stuff drifting down from a high concentration to a low concentration. You're maintaining that low concentration by driving fluid running past it, and that's the dialysis component, okay? And this is very good for clearing small molecules because it's got to happen quickly. So solute clearance will obviously depend on things like molecular size, smaller the better, charge, lesser the better, the proportion of free drug or toxin or whatever it is you're trying to clear, which will depend on its distribution in the body and its protein binding, particularly in blood. And then basic things like what's the blood flow rate and what's the dialysis flow rate, because increasing either of those will potentially increase your clearance. Similarly, the concentration gradient is important. The higher the concentration gradient, the more pressure there is for it to move across, and the membrane surface area. Now, we can park those because a lot of them we will repeat in the hemofiltration section, so that's okay. Hemofiltration, we've all seen, is, again, solute movement, which is now occurring by convection or solvent drag. It's basically we're stripping off salty water using a pump. So it's convection due to a pressure gradient across the membrane, and this is better for clearing middle and large molecules. It will clear smaller molecules, but it's also very good at larger molecules. And what we need to replace in this situation is a replacement fluid, okay? So we don't have a dialysate running. We replace the fluid that we've effectively sucked out or pushed out of the blood. So solute clearance will now be dependent on blood flow, which creates your positive pressure, your effluent flow, which is the negative pressure you suck on your pump, okay, the concentration in the blood, and something which we call the sieving coefficient. And that's a super summary of all of the things we've already talked about in terms of solute clearance for hemodialysis, which is the size, the permeability, the molecular weight, the charge, all those sorts of things. So many of the drugs we have in ICU have a sieving coefficient that's very close to 1, which means they get stripped off with hemofiltration very efficiently. Unfortunately, many of the drugs that patients take to try and kill themselves have a very low sieving coefficient, so hemofiltration is not necessarily all that efficient at removing them. That's by the by. But having an idea of a sieving coefficient tells you a little bit about how efficiently things will be removed in hemofiltration. So that's hemodialysis and hemofiltration, a little bit about solute clearance on each, and a little bit about the basic principles of their function. So now that's 80% of your mark. So now all you've got to do is, with all due respect, bullshit your way through the replacement fluid, okay? Now, you know that the replacement fluid is a big bag of effectively water, so sterile water. There's your first component. There's often electrolytes in that fluid, pretty close to plasma. So you can just write them down then, can't you? It'll have sodium, chloride. It might have potassium. It may or may not have calcium. If you're running citrate as your anticoagulant, you won't have calcium in it, but it might have magnesium and phosphate. And those concentrations can be varied depending on what you're trying to clear. Then there's almost always some form of buffer to bring the solution back to a pH closer to normal, or to bring a strong ion difference closer to normal. And that buffer is usually sodium bicarbonate or sodium lactate as the salt. And that's pretty much what's in a replacement solution. So if you write down water, salt, and buffer, you've basically passed 20% of the marks of the question. So despite this question looking terribly difficult and, oh my God, it's so confusing, if you just slow yourself down and break it down into, well, they're asking me about hemodialysis, don't know anything about that. Hemofiltration, I write that every day. Factors affecting clearance, well, I know what we're trying to clear when we're using it, so I can write a little bit about those molecules, and I know the principles of Starling's forces, so I can write something about that. And the replacement fluids, well, I know that because I've seen the bag hanging and I can make that up. And you've almost got enough to get yourself through that question without actually knowing any detail. So again, some of these questions, if you just don't panic and write what you know, you'll probably get yourself pretty close to passing.
Thanks, Mike. I guess one of the confusion from the candidates was how much depth examiners would expect in this type of questions, because when you look at some of the answers on some of the online website, that there is a lot of equations written, and then there's a coefficients and what this coefficient means, and all this forces proportionate to each other.
I think as a general rule, one A4 page of 12 font is more than enough. And if you write it down, if you write using normal 6mm lines or whatever it is, one page of A4, there is 20 marks out of 20 on that page. So you do not need to go into incredible detail. You don't have time. So, if you can't write 9 minutes on a page, that's it. So it's pointless trying to write 13 minutes worth of answer to get all of the detail that's in one of those perfect answers online. You are much better off trying to get as much as you can in 8 minutes on an A4 page and seeing if you can write a little bit on each of the components of the question. And I think it's a good exam technique for people to practice looking at how the question's written and trying to work out what percentages are being asked. If they've asked for 4 things, that's going to be a quarter, a quarter, a quarter, a quarter, unless they want us to specify or want to spend more time on one component, in which case the examiners will almost always put in the question 50% of the marks on this bit and then the rest of the marks on the other thing. And then think to yourself, well, I'm going to divide up my 1 page or 2 pages in my exam booklet into roughly that much each, and then write to fill that space. And, as much as you can in the time you have allotted to that question, 8 minutes on the exam day, plus or minus a minute at the end to come back and write a bit extra, is enough, because you are under stress, so you will underperform. But trying to write a model answer and even trying to learn model answers is not necessarily the way to go. I would practice aiming for about 80% for most questions so that you don't leave time where you haven't answered other questions. And this question looks hard, and it may not be something you've studied, but if you just remember yourself standing on the ICU ward round, having recovered from having to examine the cranial nerves on the patient before you and thinking to yourself, how am I going to write this hemofiltration prescription and what am I trying to achieve? You'll be able to answer this question. So again, it's core business in ICU. That's why we write these questions.
Thanks, Mike. That's a very useful tip for all the candidates. I guess first and foremost is that don't panic and then try to rationally write the answer. Only thing I disagree with Mike is don't BS your way through the answer, because a lot of examiner panel might not agree with the BSing in these kind of situations.
A little bit of BS goes a long way, Swapnil, as you well know.
That's right. Back in our old days, that worked well. I don't think this will work nowadays. But thanks, Mike. That's very useful. So we'll be back with another snippet in week's time. Till then, goodbye and have a nice time.
Good luck, everybody. Have fun.